to welcome clinical psychologist Dr. Saltzman with Chicago Mind Solutions for our program tonight, Healthy Mind Solutions, Healthy Brain Initiatives. Dr. Saltzman earned his doctorate from the Chicago School of Professional Psychology and his master's in vocation rehabilitation from the Illinois Institute of Technology.
I'm Dr. Saltzman. My first slide here is a little bit about me, but already mentioned I got my doctorate from the Chicago School of Professional Psychology. I have a master's in vocational rehabilitation from the Illinois Institute of Technology. And I'm currently working at an agency called Chicago Mind Solutions here in Northbrook, where we do a lot of work with a lot of different things. One of the cool things we do that's related to dementia, which we'll be talking about, is we do neuropsychological assessments. We can test people to see how their cognitive functions are. And we do something called neurofeedback. We can actually train the brain to operate differently, which has some research, but I'll go into a little bit more later on, which has some evidence that it works for different versions of dementia and different cognitive decline. I've been working with children, adults, adolescents, everything. I've worked in lots of different types of places, partial hospital programs, private practices, residential facilities. But yeah, no, I really have enjoyed working in Northbrook with the people around here. So I'm excited to do this presentation. All right, so today we will be talking about dementia and the different versions of dementia and how to live a healthy lifestyle, how to keep your brain healthy, and what dementia is and all that stuff. So yeah, we're just gonna start off with generally what is dementia. It's a collective term used to describe a collection of symptoms. I'm just gonna kind of read off the slide here a little bit, but I'll go into more detail. Generally, it's a degenerative, progressive disorder where we see declines in memory, reasoning, communication skills. There's also a lot of behavioral changes, emotional changes that can come along with it. The big thing that makes dementia its own category is that it is this progressive decline in a lot of different kind of cognitive functions. They can come from a lot of different places. There's probably over 100 different disorders that include dementia. There's a lot of like different biological, physical maladies that also include dementia. But in the most part, they're due to structural or chemical changes in the brain. As a result of, a lot of times physical diseases such as like Alzheimer's disease is a pretty common one. All dementias, regardless of the underlying disease, are progressive. Like I mentioned, life expectancy generally after diagnosis is like 8 to 12 years or so. The biggest thing to always remember about dementia is that every person with dementia is different. I had one professor who I said, if you meet one person with dementia, then you've met one person with dementia. That's it. Everyone's a little bit different. Depending on which areas of the brain are affected, people are going to behave differently. Depending on how the person was before the diagnosis, they're going to act differently. So it's never really just one thing. It's a very wide range of different things. Moving on. So people who generally get dementia, it is typically associated with older population. The rates of people who get dementia or diagnosed, it does increase with age. It's pretty rare in young and middle-aged adults. Usually you can see the stats there, about 0.5%. It's 0.5% of the population usually gets it, not 0.5% of people with dementia are in that age range. At age 60, it's already increased a lot. We've got about 1 in 100 people age 60 might be diagnosed with dementia. Keeps climbing at 65, looking at 5 to 8%. By 74, we're at 15 to 20%, and then by 85, the prevalence is from 30 to 50%. The reason these numbers are so wide in range is because, again, dementia is a little bit difficult to diagnose. If you've got kind of severe dementia, it's pretty obvious. But if there's kind of like more milder versions of dementia, it can be kind of hard to pick out sometimes versus just kind of general decline in cognition, which is very typical, very common as you get older. But again, the rule of thumb, the older you get, the more likely to be diagnosed with dementia. A little bit, we talked about the symptoms of dementia, but we have more specific here. Dementia is a lot of times associated, the main one that people associate with dementia, especially if you're thinking of the main culprit, which is Alzheimer's, is loss of memory, right? Just difficulty kind of keeping track of where things are, what's going on. The biggest question I always get when people are concerned about dementia is like, oh, I've been forgetting a lot more. I'm seeing this, that, and the other. It's there's a difference between dementia memory loss versus normal memory loss. We're going to get into that a little bit more when we get into the Alzheimer's. But memory loss is a very common, very standard symptom of dementia. There's different versions of memory as well that are affected differently depending on the person. Sometimes it's what's called procedural memory, you forget how to do things. Sometimes it's semantic memory, you just forget kind of events throughout your day. Again, there are different versions of how it happens. It's progressive. I'm gonna be saying that a lot, but yeah, loss of memory is a big one. It's the one I have on the slide here is difficulty recalling events that happened recently. So more like short-term memory. A lot of times, as it progresses, it kind of moves into that long-term memory more. Another thing is this executive functioning system. I have here on the slide the concentration, planning, and organizing. But in general, we're looking at kind of what's called executive functions. It's those higher order skills that make humans kind of the more intelligent creatures on Earth. There's a couple more examples in here: the difficulty making decisions, solving problems, or carrying out a sequence of tasks. This is when people talk about cognitive, like general cognitive decline. This is a lot of times what they're referring to, these executive functions. These, again, higher order processes, memories in there as well, but the focus, attention, organization, like you can see someone, a lot of times you'll hit people, oh, they're slipping, this person's slipping, cognitively at least. That is the executive functions that they're talking about. And another big one is language. There's a lot of parts of our brain that are responsible for language, and if some of them start progressively declining, we're going to see those changes happen in the person's verbalizations. So there's two kind of areas of language. There's expressive and receptive. Expressive is what it sounds like is expressing yourself, and receptive is the other one, understanding. And people with dementia can experience both of those. We can see them having difficulties understanding what people are saying, and they can have difficulty finding the right words for what they're looking for. We'll get into this more in a moment as well, but the difficulties with language a lot of times contribute to other difficulties that the person's experiencing. Another category, I think I must have forgot to put it on here, but we'll also address it later, is we'll see like behavioral changes. This is something that it kind of goes along with all these things as well. Someone who has a hard time concentrating, they're gonna kind of compensate for it in different ways. Someone with language difficulties is going to have to find other ways to communicate. So we can see sometimes changes in behaviors, sometimes more adaptive than others. But yeah, we'll talk about that in a moment. Okay, sorry, excuse all the click. I got a lot of things on the screen. I got to click and move around. So dementias are part of what's called the DSM-5 neurocognitive disorders. The DSM is a statistical manual, stands for the Diagnostic and Statistical Manual. It's the big old book we use to help understand how to diagnose people, what criteria a person needs to meet for certain diagnoses. And it's split into different categories. This one here is neurocognitive disorders, which is what dementia falls under. It includes things like deliriums, excuse me, symptoms of major neurocognitive disorders, and their etiological subtypes. Just like, again, I mentioned before, there could be over 100 different versions, who knows, but they would all fall into this category. The primary clinical deficit is cognitive functions. Those are the kind of like executive functions and memory we were talking about. And they're acquired rather than developmental. That means that you're not necessarily able to detect this from birth. This is something that can come, it's not necessarily inherited. You don't like kind of get it from something you ate or something you did, but over time it develops rather than being able to like a marker from early on. Although, and then the final one, there's cognitive deficits in a lot of different diagnoses, schizophrenia, bipolar, even just kind of general things like anxiety, depression, you'll see these cognitive declines. But what's different about neurocognitive disorders, it's when the core feature is cognitive, right? The main thing going on is this kind of cognitive decline rather than like schizophrenia, where you're going to see these kind of manic episodes, rather than kind of anxiety, depression, where it's more emotional in nature as the kind of underlying thing. For neurocognitive disorders, we're looking at the cognitive decline as the main source, as the thing to kind of treat. Okay, yeah, there's a couple, as I mentioned, there's lots of different types of dementia. These are some like the 4.5. We'll talk about delirium in a moment, but these are kind of the 4 main ones. I'm sure everyone's heard of Alzheimer's. Maybe not so much the other 3 on here. I'm sure, and delirium again sort of fits. We'll address that in a moment. But yeah, there's lots of types of dementia. These are the most common. So the first one we will start with is Alzheimer's. Again, the main one that people are associated with, it is the most common version that when you see someone have dementia, and some of the markers are you become confused, frequently forget the names of people, places, and appointments. This is where I like to explain, like if I don't like to explain it, but if I have to explain the difference between dementia and just general memory loss, you know, if you walk into the kitchen and you forget what you went in there to do, like was I here to make lunch? Was I here to like grab my keys? That's kind of general memory loss. If you go into the kitchen and you forget what a kitchen is, if you don't know what that room, if you don't know where you are in the house, if you don't recognize the kitchen at all, that's a cognitive issue, right? That's a cognitive decline. That's when we're like, okay, this might be dementia. This is Alzheimer's. It's a very different level. Anyway, there's a lot, as I mentioned before, things like the language, things like the executive functioning can lead to other difficulties. So we can see these kind of mood swings, these emotional difficulties, the anxiety, depression from recognizing that like I'm struggling with things I didn't always struggle with. A lot of people become more withdrawn because they don't want to experience those things. It's difficult for them to communicate, so they just don't want to go out and experience those things. And again, you know, those cognitive declines are going to very heavily influence daily activities, things like that. And then the cause of Alzheimer's is proteins that get tangled up in the brain. The brain cells are surrounded by an abnormal protein, and their internal structure is also damaged. In time, the chemical connections between the brain cells are lost and the cells die. That's where this decline comes from. It can happen in like various parts of the brain to start with. It can kind of move around in different patterns. Again, this is why everyone with dementia looks a little bit different. Different parts of the brain are being affected at different stages of the disease's progress. There are some medications that can help improve the symptoms. It even may stop the progression for like a short while. Can like relieve some of the memory problems. It can improve alertness. But at the end of the day, like it's still going to keep progressing. There's so far, as far as I know, there is nothing that has shown to like stop or reverse the effects of dementia, specifically with Alzheimer's. But there are some medications that can kind of help the process. Okay, the next one on the list is called vascular dementia. This is going to look a little bit different. I mean, all the dementias, different versions are going to be somewhat similar. This vascular dementia is caused by problems with blood flow to the brain. So like if the oxygen and nutrient supply to the brain is reduced, sometimes because of narrowing of the blood vessels, sometimes because of blockage in the blood vessels, this is the mechanism with which the brain cells can become damaged or they can die. It can appear kind of suddenly, and it might coincide with a stroke. Like maybe there's like someone has a large stroke, which can kind of kickstart this process. Sometimes it can even be someone who's had multiple minor strokes over time. But in some form of another, the blood supply, the oxygen supply to the brain has been damaged, and that's where we see these cells start dying. In vascular dementia, we see a lot of problems more with speed of the thinking, the concentration and communication. Similarly, the depression and anxiety accompany the dementia for similar reasons as with Alzheimer's. We'll have periods of severe confusion, prone to delirium, which we'll get to in a moment. And then, yeah, there's kind of also this mixed version of dementia, where you might have the Alzheimer's, which is more of a biological disease in nature, and then you might also have kind of a stroke on top of it, multiple little strokes on top of it. So we have that would get obviously much more complicated and confusing. And you would also then see kind of a mixture of symptoms from the two different dementias happening at once. In the case of vascular dementia or mixed dementia, we would try and treat the underlying process first, right? If we can kind of address the issues of blood flow to the brain, we might see a little bit of improvement. We might see that progression kind of slow down. At the end of the day, though, a lot of times it is, as far as I know, there isn't a way to, again, stop it or completely reverse it. But yeah, there are these, that one again is more to do with the blood flow. So if we can address the blood flow, we can address kind of the things we're seeing. All right, the next one on here is called Lewy body. There we go. Sorry for the small print. There was a lot to write on this one. Yeah, this one you're going to experience problems more with attention and alertness. Sometimes there's also spatial disorientation that has to do with just, again, the different versions of the different areas of the brain that are affected. This is one of the dementias that are related to Parkinson's disease. You're going to see a lot of similar, excuse me, a lot of similar symptoms that we would see for someone who has Parkinson's, including like slowness, the muscle stiffness, trembling and shuffling, the loss of brain cells and synapses, and the loss of neurotransmitter acetylcholine are a big contribution to how Lewy body dementia happens. We have it's very people who have Lewy body dementia are very sensitive to antipsychotic medication. We see a lot, again, it's a lot of that confusion, a lot of that, one of the their consciousness can kind of fluctuate a lot. They can sometimes be very aware of what's going on in their world, and sometimes can feel like they're totally out of it. This one, Lewy body, is caused by clumps of protein. They develop inside the nerves, and they can just kind of block the messages to the brain. That's the acetylcholine that I was mentioning before. That's a neurotransmitter, one of the chemicals in the brain. Dementia with Lewy bodies is diagnosed when the symptoms of dementia appear before or at the same time as Parkinson's symptoms. The reverse is true as well. It would be then the Parkinson's dementia when it goes the other way. Yeah, okay. The next one on the list is called frontotemporal. My computer looks like it's freezing a second. Anytime now. There we go. Frontotemporal dementia is probably the most descriptive of the dementias because it describes where in the brain it's happening. Fronto is the frontal lobe, temporal lobe exists back here. So we're talking about dementia that has, maybe there's a lesion going on that's how it started, but in some way the frontal lobe and the temporal lobe are being affected, usually most, but also usually first. We see with people with frontotemporal dementia, there's a lack of insight and there's a loss of ability to empathize with others, so that like kind of human connection can kind of be lost. They're more likely to have difficulties with language and emotional responses, and that is actually very common to that area of the brain. We have a couple areas of the brain right on that frontal temporal junction. The first one is the amygdala, which is a little almond-shaped area right inside, like right behind the temple. So it's a inner structure of the brain, so it's not right on the surface. That's the cortex. But inside the brain a little bit more, we have the amygdala, which is responsible for emotion regulation. And then right over here on the left side of the brain, right in that same area, something called Broca's area. Broca's area is responsible for expressive language, and that again is on the surface. That is much more likely to be affected by frontotemporal. It is a very common symptom of frontotemporal, although frontotemporal dementia is fairly rare. Again, the frontal and temporal lobe are damaged over time when clumps of abnormal proteins form inside the nerve cells, same as the Lewy bodies. It's sometimes known as Pick's disease as well, if that comes up. Let's see, did I miss anything? This one's my favorite, that's why. Yeah, it's because it's very brain oriented, so I like that one. A lot of people, they can lose inhibitions. It's like similarly related to that empathy area. You're losing that kind of human connection. They're not understanding the situations you're in. You're not really understanding the people around you. So you can be a little bit more inhibited by those kind of things. All right, those are the four main dementias. I think there's a lot of other ones out there, but then there's one more that comes up a lot, delirium specifically. Delirium is a little bit different. It is included in the DSM under the neurocognitive disorders, the same as the dementias. It's a little bit different because delirium is an acute condition where dementia is much more chronic, much more lifelong. It does come with a kind of it's usually fatal after 8 to 12 years, whereas delirium can be very temporary. As it's written here, there's a sudden onset of confusion, a sudden onset of deterioration into cognition, which can look a lot like dementia. This can affect any ages though. You generally treat the cause and the symptoms improve, right? Delirium can come about from malnourishment, from dehydration. It can come about from drug use or stress. Lots of different things can kind of cause this kind of break from reality temporarily, which looks a lot like dementia. But if those underlying causes are treated, the delirium usually subsides. If the person is able to kind of maintain a healthy balance from what caused the original episode of delirium, it usually doesn't happen again. People with dementia are more likely to experience delirium. So if you are kind of in the earlier stages of dementia, if you have a version of dementia where you have lucidity like throughout the course of your day, whatever, you may still experience those delirium, those states of delirium. Yeah, all right. So that's the main thing to look for. Those are the main kind of versions of dementia. That's kind of what they look like. Very similar throughout. It's a really, if someone you know is experiencing kind of these symptoms, there's a couple ways to find out, but you really have to go through the assessment process to figure out which version of dementia and how to best go about it, which we'll discuss in a moment. But before we get to that, these are some of the kind of common difficulties with all dementias and delirium. Like I mentioned before, communication. I have a couple things mentioned here. This one, expressive language is difficult. That area of the brain is very sensitive. We see difficulties with expressive language in lots of different disorders. Anytime when that Broca's area or any parts of the brain that are connected to it are damaged, it's hard to find the words you're looking for. This can lead to a lot of different things, right? A lot of people with dementia may gesture more than they speak. They may just decide not to speak at all. They have hard times remembering names of people, places, objects. Sometimes you'll find them repeating themselves over and over again. It is linked heavily with like different versions of aphasia and things like that. It's usually aphasia is more specifically to language, whereas dementia kind of can look like aphasia. Aphasia being a difficulty with speaking, sorry. But yeah, and then there's also the receptive language piece as well. Communication just in general kind of declines with dementia, which can also lead to behavioral difficulties, right? I kind of mentioned this before. A lot of times the behavioral difficulties are the result of the other difficulties we see from dementia. So for instance, if someone is having difficulty communicating, they might change, they might gesture more, they might become more withdrawn, they might get angry when they can't express themselves. Similarly, like in general, the emotional functioning of a person with dementia is going to change. It can change because of the difficulties they might have. Someone who all of a sudden, can't do the things they used to be able to do, is recognizing the difficulties they're having, they might experience that kind of anxiety, depression. There might be kind of self-concept issues and things like that. Very common in people with dementia. This can lead to difficulties in behavior. Excuse me. A lot of times it is also, coming from a more therapy perspective, it is kind of a very in your face, like this might be the end. This is where you're kind of getting in touch with your mortality. And a lot of people can become fearful or anxious from this difficulty. They kind of recognize their cognitions are declining, they're having these difficulties, it's difficult. It's a tough spot to be in for a lot of people. Let's see. Yeah, delusions and hallucinations, that can happen as well. If your occipital lobe, that's the one in the back that's responsible for visual processing, if that starts getting affected, you might be seeing, hearing, smelling things that aren't around, that you're experiencing things that no one else is experiencing. That can be a little terrifying. It's always important to remember dementia. Dementia is not something that kind of you grew up with. It all of a sudden just kind of jumps on you and then progresses sometimes very rapidly. Different versions can be more aggressive, and especially if you're not receiving any treatment or something, then a lot of these symptoms can kind of come out of nowhere. So that could be very difficult for a lot of people, and can lead to behavior changes for them to kind of help deal with this new emotional pain in their life. Sometimes the behavior changes are also just due to them having difficulty getting their needs met. If they are having a hard time expressing that they're hungry, thirsty, or just want to talk to someone, they might notice that other people around them are treating them differently or acting differently. It's a kind of a double-edged sword, because on the one hand, you're still aware of how things used to be. Sometimes how things used to be, you're aware that things are changing, but you also really can't do anything to reverse it in a lot of ways. All right. Yeah. So now we can get into a little bit how to prevent it, how to work towards a healthy lifestyle. That is the main point. After all the negatives and being so down, we have a little bit of hope, light at the end of the tunnel. There are some things that have been shown. Unfortunately, there still is no one solid piece of evidence that says, here's how to stop dementia, here's how to stop Alzheimer's. There's no, magic bullet treatment for any of these things. But there are some things that can slow the progress. There are some things that can kind of lower your odds of contracting one of these illnesses. The main thing out there is that living a healthy lifestyle, right? The evidence indicates that certain medical conditions, we're talking about high blood pressure, diabetes, and obesity, increase the risk of dementia. So, exercise, eat healthy, keep your brain sharp, keeping all those things in line. Think about vascular dementia specifically. If you're having, if blood flow to your brain gets cut off, that can kind of trigger dementia. So the best way to keep blood flow, oxygen flow to your brain at a good state is by making sure your arteries, your veins are nice and clear, they're flowing well, you're getting enough of that oxygen, and exercise and dieting are two of the best ways to get that done. This does apply to all the versions of dementia. I just thinking it in terms of the vascular dementia is I think one of the more helpful ways, because it's a much more direct correlation. Okay. Why would we? Sorry about that. Why would we diagnose or treat any of the dementias early? The same reason we want to do it for anything. We want to improve the quality of life. The earlier that we can address, the earlier we can identify something, the earlier we can address it, the better usually the prognosis is for the person. We can see the changes slow, like that degenerative progression slowed down a little bit. We can help the person build the skills necessary to compensate for whatever difficulties they have. For instance, communication. If we see the communication is declining early on, we can introduce other forms of communication. There's a lot of you can have even just a writing pad sometimes is all that's needed. But there are some assistive technologies as well. There's computers that they can just type into that speaks for them. There can be like booklets full of cards that can help them kind of recognize what they want. Yeah, there's the earlier you can assess and treat this, the earlier we can kind of build skills into it. And that it will improve the quality of life for people with dementia. Let's see, do we have anything there? Yeah, that's from the kind of legal standpoint. It allows family members to, if you wanted to do power of attorney, if you needed to do any of those things in order to kind of prepare the person for the changes that might be occurring for the end of life kind of things, then you can start getting that ready earlier. It won't it won't surprise you as much. We do. While everyone with dementia looks different, we do kind of know overall what might happen, what it's going to look like, what the difficulties are going to be. There are certain patterns to these things, and we can kind of prepare ourselves for when our loved ones are struggling with these things to make their lives and our lives a little bit as smooth as possible through the process. Okay. Yeah, this is a good one. Stigma is always a big one, right? People with Alzheimer's, people with dementia are heavily stigmatized. They're portrayed in the media very poorly. This can also, you can kind of, the earlier you find out about it, the better you can kind of start working with those around you to understand what's going on. You can keep your loved ones in the loop. You can bring them into the family and things like that, so that people don't become, let's be honest, don't become scared, or they don't become angry or things like that, which is also common responses to people with dementia. It's like, all of a sudden grandpa can't do the things he used to do. Well, why not? So this will kind of help with that a little bit. And this is all really just to improve the quality of life for the person with dementia. Okay. And now, talking about how to diagnose dementia, there's a few ways to diagnose depending on what we're looking for. As I was mentioning before, there are a lot of versions of dementia, a lot of different diseases that can lead to it, and some of it, like I'm a psychologist, so I do more of the cognitive side of things. But a medical doctor can diagnose this as well. Blood tests can rule out physical health reasons for impaired memory. They can determine if one of those blood clots or if their stroke was happening. They can determine if there are certain diseases going on. Where the kind of psychology side of thing comes in, something that again we do at Chicago Mind Solutions, is the cognitive test of mental abilities. So we have a couple of versions on there. There's the ACE-3, the WAIS, the NAB. There's a lot of different tests that measure different levels of cognition. Something that is an interesting addition that a lot of these assessments do is also something called malingering. If a person's kind of pretending they have dementia, we can test for that as well, just to see what's going on. But these different tests will take the person's abilities, they'll take the person's scores, and they will compare them to where we would expect that person to be if there was no dementia, and we can see how far away they are, how well they're doing. We can even track decline if that's something we would do it once every 6 months or something, give the kind of same test over again. That would help understand how the disease is progressing, how the changes are progressing, and things like that. Sometimes the diagnosis can take a while. It depends how booked the places you're going. Sometimes it can take up to weeks or months. Sometimes you can do the testing, and I wouldn't say the results come back inconclusive, but the results wouldn't be enough to make a diagnosis, at least especially in the earlier stages. So again, it is something, as soon as you kind of have this idea, you definitely want to get on, you definitely want to schedule one of those things to make that happen. Another thing that can help is a scan of the brain. There are a lot of different types of brain scans. I'm sure most of you have heard of an MRI or an fMRI. There's also things called a PET scan, a SPECT scan, a CAT scan, things like that. Different versions of brain scans will monitor different things. Some of them will look at blood flow, some of them look at oxygen, some of them look more structurally, some of them can look at how the brain is functioning over time. So it'll take more of a video rather than a picture. Any one of them can be a good starting spot. It depends on what eventually comes out. If, for instance, you get an MRI, that is going to just take kind of like pictures of the brain to look for structural damage. But if the issue is more vascular in nature, if it's blood flow, that might not show up on an MRI. So you're going to need like a SPECT scan, and that's going to show the blood flow a little more. An fMRI would show the blood flow a little bit more, the oxygen. So again, it might take this is where it goes back in. It might take a couple months, a couple weeks before you get the test that is accurate in finding what needs to be found to make the accurate diagnosis. Something also to keep in mind is some people might not want a diagnosis. It is, again, going back to before, it's a scary place to be, to find that there's just, it's unfortunately there's nothing we can do when someone is diagnosed with dementia. Well, we can slow the process down, but there is a definitive end. So a lot of people might not want to find out about it. They might be worried about finding out about it. And that's going to be kind of your call. My suggestion would be to find this out. The earlier we know about it, the more we can do, the more we can improve that quality of life as a person is going through this process. There are a lot of memory services out there other than like your general practitioner. There are things that can provide cognitive stimulation. There are things that can provide cognitive therapy to build some of the skills that are being lost as the person progresses. The brain scan can help identify sometimes what areas of the brain are being affected, and we can do certain training in that way as well. That's one of the things that neurofeedback can do. We can kind of train the areas of the brain to give more power or take away power depending on which areas, what areas are doing too much or too little. Again, this is something that can also be looked at from a more medical biological perspective. Someone who has high cholesterol, that might be something that tips them off. Someone who has a couple strokes, that might be something that kind of tips the scales for a diagnosis as well. Okay, let's go on to the next one. There we go. When you are someone you love is diagnosed with dementia, there are still ways to live well. This is not like the end of the line. Diagnosis of dementia might bring some challenges, but a lot of people with dementia kind of want to just go about their daily lives, their normal everyday lives, as we all would if we were diagnosed with something. So we want to support them as much as possible. There are a lot of ways around that. We were talking about kind of the assistive technologies from before that can help out, but there's also more kind of practical, pragmatic methods to just kind of change your area around you to match that. This can include things just like making different things, different colors in the house, for instance. If you can just put labels on different things to help people remember what's going on. Keeping a pad of paper with you to write things down. Any of the little things that can help make that progressive decline a little bit easier as the person is going through these changes. A lot of it can also be with the community, keeping them involved with community partnerships, community events, getting out of the house and doing things. We talked about how a lot of people with dementia can feel withdrawn. So finding things for them to do, finding other groups where they can still participate, be a part of, that would just, again, improve the quality of life. Some of the other kind of ways to combat dementia, we mentioned before, there are certain medications that can slow the progress. So, make sure always talking with your general practitioner about those kind of things. And then something called that again we do here is called neurofeedback. Expressive language is a really good version of that. A lot of times from patients with dementia, we'll see again that Broca's area over here, as those cells are dying, we can see less energy in that area. We do a brain scan, and we can see less energy in that area. Over time, we can, through operative conditioning, we can increase the energy in that area. We can, and that's just one example, but we can kind of make that area of the brain work a little bit harder. We can show that area of the brain how to kind of increase its capacities and things like that. And that can work as well for memory, for attention, for focus. There's a lot of things that we can still do to make sure that people with dementia are living well and living their best lives. That's what sorry, I kind of flew through that all. And I don't see any questions yet, but is there anything? That's kind of it for the presentation, I suppose. Is there any questions?
I actually have a question. So overall, does it tend to be hereditary, or is it more of an environmental thing?
It's a little, that's an excellent question. It can be hereditary, right? Things like Alzheimer's, it's very similar to Parkinson's, to Huntington's and things like that, where there are kind of hereditary markers. Unfortunately, a lot of it can't be picked up until that's what I was saying earlier on. It is not something we see that's developmental, but it is like if your grandfather had it, if your parents had it, then we can see there are patterns. There are again, patterns, I guess is the best word I can think of, where families can have hereditary signs of dementia. Environmentally, not as much, other than talking about kind of healthy lifestyle, right? A lot of times healthy lifestyle is environmental. If it's hard to kind of get healthy food, if there's not a lot of areas to exercise, you're thinking about kind of inner city kids, things like that. It is a lot harder to kind of keep that healthy lifestyle that would lead to a lesser chance of dementia. Usually when I think environmental, I think of like toxins in the environment, and that, as far as I know, does not lead to, it wouldn't be dementia necessarily. You might see kind of signs of dementia in the same way someone with bipolar schizophrenia would also show signs of dementia. It wouldn't be diagnosed in the same way as dementia, because it would be more a different source. It would be more like almost like a drug reaction. Like if someone overdosed on a different medication or something, they could show signs of dementia, which would, again, look like it a lot, but it would just be a very different version. Does that help?
Yes, it does. Thank you.
Yeah, no problem. Okay, it looks like we have a question. Is it possible that someone could think they have dementia, but it could be something else entirely? Yes, definitely. There's a lot of things that look like dementia. I'm gonna see which one was that. I had one of the slides had something like that on it. Yeah, it's not important. There's dementia is basically like this cognitive decline, and cognitive decline is a very broad term. There's a lot of things that can fit under that, including things like memory loss, including things like kind of disassociation from the environment, and those kind of things fit under a lot of different categories. The main one, I think that the one that I shouldn't say the main one, the one that I see a lot, people will come in and say they're having issues with memory and they think it's dementia. Memory loss is very typical as people age. Cognitive decline is very typical as people age. It's how it's progressing as a decline, and it's what areas are progressing, of what areas of the brain are declining as it progresses on. And that's where, again, the assessment portion is so important to really determine if it is at the level where we're talking about dementia versus kind of normal decline, or if it is a different thing entirely. I used to work at a place called Thresholds, which dealt with people with severe mental illness, schizophrenia, a lot of different versions of dissociative identity disorder and things like that. And it can look very similar to dementia, where they wouldn't remember who I am most of the time. They wouldn't know where they were. A lot of times you'd still see those same hallucinations, delusions that you also see in dementia, but they come from a different source. For instance, I shouldn't say a lot of, but there were some people who I was working with at that location, where if we somehow were able to kind of get them off their meds, or if we could help them manage their medications better, we would stop seeing those same responses. Whereas with dementia, there's really no way to kind of turn it off. Well, some people have periods of lucidity, but there's no way to like force it to turn off, if that makes sense. Yeah, I hope that answers your question. But I see another question on there as well. Do you test for tingles in the brain? We do not test for tingles in the brain. That would be more if you found like the fMRI or a SPECT scan. We do something here called a QEEG. We look at the electrical activity in the brain. So we can see which areas of the brain are, again, like I was mentioning before, too much power or not enough power. Power in the brain, energy in the brain is determined based on, like, so if we put a little sensor right here, if there's a lot of neurons firing, we'll see a lot of energy there. If the neurons are spread out, if there's not a lot of neurons there, we'll see lower amounts of energy in those areas. So what that can tell us is if different areas of the brain have started losing power, some of those cells have started dying, things like that. And then we can work to increase the power there. We can't necessarily make, it's not going to make more energy, but it's going to help those areas of the brain work harder. But it's not going to, that doesn't hurt or anything. It's not going to tire anyone out and anything like that. It's just training those areas of the brain. Hey, pick up the pace a little bit more. And we can see the symptoms of dementia lessen. Again, there's no stopping the actual progression of the diseases, but we can slow down the symptoms of progress. If you wanted to, again, test for specific tangles in the brain, depending on what the tangles look like, a lot of times it is more vascular in nature. So you'd have to get a scan that looks at blood flow, which is, again, fMRI or a SPECT. Sometimes the tangles can be more visible physically. So you need a structural imaging, which would be an MRI or something, or a CAT scan, would show you if there's actual tangles. Sometimes they're visible, sometimes they're not. We're talking about, at the cellular level. So it's sometimes it might, this is where like the inconclusive word I don't like throwing around, because it can be hard to like specifically diagnose based on one scan, but you can find some evidence, just again, based on one scan, but multiple scans or the testing can really show a lot of things like that. All right, I hope that answers that question.
I actually have another question. Can you
Sure.
give an example of what cognitive stimulation might look like for someone who may be trying to help someone at home? I do know someone who's in their 90s and she has undiagnosed dementia, but I don't think she's real willing to get out there and hang out with the doctors. Is there something
Sure.
that people can do at home?
Yeah, and that's going to be, again, so it's an excellent question. That's going to be specific to the person. So for instance, talking about communication, the way to kind of stimulate those areas, there's a couple versions of answers to this question. The first thing I'm thinking of, something you can do at home is actually, like, I kind of hate to make this comparison, but it's something that we would do with like children who would be focusing on the same thing. So for instance, if someone is having difficulty expressing themselves, communicating in that manner, we would kind of approach it the same way we might approach a child who's having the difficulties. So maybe you would put some like key words on the wall, and you can help, like, okay, what is it that you need here? You would help the person recognize, like, okay, these are the words that you need in these moments. How can we remember how to use them? How can you help identify which ones they are? Things like that. There's one trick I learned from one of the other doctors who works here. He does something called cognitive rehabilitation, which is more specific, I think, is actually exactly what you're talking about. But if someone doesn't want to come out and see the doctors, then that's not going to help too much either. But what he says is a lot of people with dementia, sometimes they have vision issues as well. So reading can become difficult. So what they'll do if they're reading is they'll read just the first half of the page and then just they'll keep going. So he'll help stimulate cognitively by saying, okay, whenever you're reading, you always have to remember, when you think you're done, just keep going. So it's those little tricks here and there that can help stimulate the person's the areas of the brain, which can help kind of like, and that's kind of also like bringing those skills in. Just teaching kind of on a practical level, here is something you can do to address this difficulty you're having. Just keep turning your head a little bit more, that kind of thing. On the other hand, we can actually stimulate the brain using the neurofeedback process more directly. There's two kind of devices we use here. One is more organic in nature, where we just kind of let the brain do its own thing, and we say like, oh, as it's making more power, good job. As it's not making more power, we say, not such a good job, go back to what you were doing before. We also have another machine where we do actually send in a very light signal. The signal is 1/1,000,000th of a cell phone signal. So think about that next time you're on your phone for a long time. And what that can actually do is stimulate the brain to fire in a way that it wasn't able to before. So again, looking at that expressive language area, if we're seeing a lot of decline there, if we're seeing very low energy there, we can actually send in a signal to that area and say, hey, power up a little bit more. And it's a really interesting process. Sometimes we'll see really just even in the moment, the person's skills will increase. Usually, over time, like if they're coming in twice a week or something, by the time they come in the next time, it's gone back to normal. But over time, as we do it more and more and more, those areas of the brain are getting trained or getting retrained to produce more energy. They're being stimulated so much, they just produce that energy themselves. So that was a really cool one too. Is that helpful? Was that what I was looking for?
That's awesome. Yeah, thank you.
Okay, cool. Yeah, we got another question here on the comments as well. What is it that the synapses don't talk to each other? I'm a little bit confused. Are you asking like what is the name of the condition where synapses don't talk to each other, or is it like a version of dementia where the synapses don't talk to each other? I'm going to start answering anyway. But basically, what it means when two synapses don't talk to each other, a synapse is actually like a space. It's the space in between two brain cells. Which version of dementia? It could really be any of them. When synapses aren't talking to each other, there could be multiple different reasons, right? When they talk, chemicals come out of one synapse and they attach to the other synapse, and that's how the communication continues on. As the synapse gets more of I brought up acetylcholine before. As acetylcholine kind of links into the brain cells, that triggers the electrical impulses up that neuron, goes down the length of the neuron, goes out of the other neuron across the synapse and continues on and on like that. When the different cells are either dying, they're not there anymore, so it has nothing to communicate, or if there are tangles, if the proteins can get tangled up in sometimes in the synapse, sometimes in the neuron itself, then we see it depends. Are they talking to each other? Where is that process of communication being interrupted? That's hard to say. It depends on which one. But either way, the outcome will look the same, where the communication is not happening. It's not going from one through the other, whether it's being cut off at the synapse, or whether it's just there's nothing there for it to talk to, or whether it's going into the next neuron but can't continue on. That's those three versions. The outcome is still going to look the same, because one way or another that neuron is not firing. It's not continuing the message. So all dementias kind of have that. Again, we're not going to like include delirium in that, because it's temporary. So like the delirium you can get that communication back. But all the versions of dementia, in one way or another, you're going to see that kind of communication between the synapses decline, if that helps. Was that what you were looking for? Honestly, yeah. I hope we got close. Yeah. Any other questions? Anything else? Okay, good, awesome. I don't know if you guys can see me.
Well, this is great. This is very informative. Thank you so much. I feel like you've given us some great tips on prevention too, which is
That was the plan.
encouraging. Yeah. So, well, thank you. I don't think I see any more questions. So just a reminder, this program was being recorded. We will have it on our YouTube channel. You can also subscribe to our YouTube channel to get reminders about other content that has just been uploaded, so that's great too. And otherwise, I hope you guys have a great night. Thank you for joining us.
Yeah, I just saw this. If you have any other questions, if you think of anything else, anyone out there, I'm going to include my email. I'm just gonna put it in the chat right now. You can always feel free to reach out with further questions. It looks like someone might have a question. They raise their hand. But yeah, I just put my email in the chat. If you have any other questions throughout, think of something that like at the time when I said it made total sense and you're thinking about it before, like I don't understand a word that guy said, you can always feel free to reach out with any questions.
Great. And if you're not able to grab that from the chat right now, I will include that information when I send out the follow-up email, which will have the recording link as well. So
awesome. Thank you.
Okay.
I don't know, it looked like there was something that said that someone raised their hand. I don't know I don't know how
If your hand was raised, if you have a quick second, you can just put that in the chat. We're not able to allow you to speak because this is the webinar version of Zoom, but
we still have a couple minutes. So if you put your question in there.
So since we do have a minute, I'll just talk really quick. We've got a really cool reading program if you guys are into reading. It's going throughout the year. So it started January, and you'll be getting reading lists if you sign up. Every month is a different list, and we're traveling around the world. So it's around the reading around the world. So for each month, we'll be concentrating on 2 different time zones within the world. So we're starting in the Chicago area in January. We're traveling west, and we're trying to see who can basically read the most pages. 1 page is equal to 1 mile around the world. So if somebody can make it all the way around the world, that's awesome. We're giving out some prizes too. So
cool.
So yeah.
That's a lot of pages.
It can be done. We did the math, and it's about, I think, 60 books the average size books. So somebody's going to do it. I have a feeling. Yeah.
Cool.
All right. Okay, well, I don't see any other questions. So if you did have a question, feel free to reach out directly to Dr. Saltzman. I'll be giving you his contact information too with my follow-up email. So.
All right.
Okay.
Thanks so much.
All right. Thank you. You guys have a good night.
All right.
Thanks.